Good afternoon from Belgium. I'm very happy to see the interest we have today and yesterday for the conference, but I can never regret the absence of the people who should attend this conference. And as Fred also emphasized this morning, they're never there. But anyhow, we should still continue to share our data and our interest. And with respect to this, I would like to furthermore emphasize the importance of searching for what I would call neglected infections and also gastrointestinal issues in late stage or persistent or chronic, whatever, vector-borne infections patients. We all know, because we are all here, that tick-borne diseases, which afflicts humans and other animals, are caused by infectious agents transmitted by tick bites, that they carry a lot of different pathogenic agents, and the tick-borne infections are increasing globally and is amongst the most prevalent vector-borne infection both in US and in Europe. But what we do not pay attention enough, in my sense, is to get the tick tested. We had a few wonderful talks this last 2 days with the importance of getting the tick tested, and I would further like to emphasize and broaden this message whenever possible, get a tick tested. We all know that Lyme disease is the most widely known tick-borne disease, but several other studies show that individual ticks can harbor more than one disease-causing agent, and patients can be infected with more than one pathogen at the same time, thus compounding the difficulty in diagnosis and treatment. And if we think that the most investigated ones are Borrelia burgdorferi sensuato, Bartonella, and Plasma rickettsia, there is a bunch more of those that really need to be taken into consideration, like Borrelia relapsing fever, Miyamotoi, and also Tularemia, Yersinia, a bunch of viruses, Mycoplasma, Chlamydia, and some others that are still not equally assessed. At the beginning, I would also like to remind that when we talk about Lyme disease, should bear in mind that tick-borne diseases can be acute or late stage, and this is important given that diagnostic and treatment approaches might be different in these two situations. We know that Lyme disease exhibits a variety of symptoms that we confounded with different other infections and afflictions, like we saw just before the launch for ME/CFS. And thus, chronic patients that have complex clinical picture with multiple afflictions need an integrative approach with multiple testing and careful interpretation of testing results. There are a lot of accents today and focus on tick-borne diseases testing with pros and cons. And I would really like to replace the importance of specialized medical device and guidance in the center of this, because still we do not have enough specialized people on board, and it's very difficult for patients to find the person who can help them. Yet another point is the importance of novel testing approaches. There are different testing approaches that are emerging worldwide, but they're not given enough visibility and enough importance. And also, for me, it is very important to emphasize the need to enlarge borreliosis-relating testing targets and not testing only for Borrelia burgdorferi sensuato, because the overall high expansion of undiagnosed Lyme disease cases worldwide might be linked to the screening choice focusing only on Borrelia burgdorferi sensuato and only rarely testing for Borrelia Miyamotoi or relapsing fever. We have been involved since several years in these novel testing approaches, and one took a lot of our energy, time, and hope. It's the Felix phage-based test. Bacteriophages could become a diagnostic tool based on the principle that if there are phages, it is because they are living bacteria. Hence, a phage-based test is a direct proof of an active infection. Felix Charity, together with Leicester University Microbiology Department, have recently developed Borrelia phage-based PCR test searching for three major Borrelia groups: Borrelia burgdorferi sensulata, Borrelia miyamotoi, and relapsing fever group. This method is efficiently used to assess both human samples and ticks. It's highly sensitive and specific, and do not generate positive signal against other bacterial strains. And very importantly, false positives are ruled out by systematic sequencing. How it works? It starts with a biological sample, as I said, tick or blood or urine or biopsy. The biological sample undergoes to manual DNA phenylchloroform extraction, and this is a very crucial step in that those automated and the techniques based on beads or columns do not give the same quality results. Once we have extracted DNA, those samples go an extensive QCA process, the first one aiming to assess the quality of extracted DNA, and the second one to certify the absence of PCR inhibitors, which is, of course, very important for PCR-based techniques. And then the sample undergo three different real-time PCR, searching for three major groups: Borrelia burgdorferi sensulata, Borrelia miyamotoi, relapsing fever group. And each sample is tested in 4 replicates per target. The positive-like results are sent for confirmatory sequencing in order to be certain that it's not something else that was amplified. We applied this technique also for tick testing, and we had the opportunity to test a large series of European ticks. We compared 2 different techniques: hybrid spot, which enables simultaneous detection of 7 tick-borne bacteria genera by PCR and dot blot with the targets spotted twice at a different place on the blot. And we compared the same DNA with Felix phage Borrelia test. 40% of our analyzed ticks were negative, no detected pathogens, while 60% were positive for at least one pathogen. When you look into detail, we were unable to find any rickettsia, ehrlichia, anaplasma, Tularemia, Bartonella, or Coxiella, and 20% were positive for Borrelia burgdorferi sensulata. Then we submitted the same DNA to Felix phage Borrelia test, focusing only on Borrelia detection, and we found pretty same percentage, 17% positive for Borrelia burgdorferi. But then we had a huge surprise. 60% of positive samples were for Borrelia miyamotoi and 23% for Borrelia relapsing fever group. Moreover, 25% of positive ticks were for 2 pathogens. We were pretty much shocked with those results, but are they really unexpected? Yes, because there were no big analysis of Borrelia miyamotoi and ticks in human samples. There were small published studies and some reports from conferences, but nothing really convincing with large data set. As I said, 60% of analyzed ticks were positive for at least one pathogen. Among them, only 17 to 20 were positive for Borrelia burgdorferi sensulata, and 60 were positive for Borrelia miyamotoi. These results are in line with those obtained on human samples. This test was done for more than 1 year on human samples, and with over 2,100 results from patients originating from various countries, we show the same proportion. 70% were positive, among which over 60 indicated presence of specific Borrelia miyamotoi phages. For more analysis of some clinical data, please refer to the next lecture from Dr. Tolier. Thus, with respect to the obtained results, we raise a question. When speaking about Lyme disease testing, are we searching for a wrong culprit? Besides Borrelia, there are several other neglected infections that need more investigation. Dr. Schwarzberg also pointed some viruses, chlamydia, mycoplasma. I don't have time to present all our data, but I would like to just show you a few data on tularemia. which is often delayed. And in some countries, like in Belgium, they even refuse to doctors to test for tularemia because they said there is no tularemia, while our 4-year testing said that on screening test, 22% were positive, and among those, 29 were confirmed by IgM IVD test, which is not negligible. The same as with Yersinia. There are a lot of Lyme patients co-infected with Yersinia. There is a lot of publications emphasizing the importance of testing for Yersinia, and our data obtained with immunoblot IgG and IgA over 4 years showed that 17% have indeed positive IgA and almost 40% positive IgG test, which again is not anecdotal. And the last part of my talk, I would like to link Lyme disease testing with intestinal dysfunction, and maybe to suggest to Professor Lambert to add yet another eye on his triad, which is intestinal. Tick-borne infections and gastrointestinal disorders have been already linked, published, discussed on different conferences, but still it's not yet widely investigated, and there is not much attention point over this this type and this focus on chronic patients. We already heard about leaky gut. In our patient population, it's over 63% of Lyme patients that are with leaky gut with high zonulin levels, and we know that lipopolysaccharides are very harmful, can induce a very strong pro-inflammatory response, and also reactivate viruses. When the leaky gut is combined with severe dysbiosis, then we have maybe part of the response on the question that Professor Horowitz said, why I can't get better? When you see the data with metagenomics stool assay from one of our patients, you can see the first visit, he had over 42% of microbiota on Prevotella and 18 on Streptococcus, while Prevotella is a very strong hydrogen sulfide producer, which is a neurotoxin. It's a metatoxic poison, and also lowering pH of gut, which means that it disables a good strains to fix. And you can see that over more than 1 year, this patient needs to normalize his microflora, intestinal microflora. Yet another example with a Lyme patient that had a combination on Prevotella and Bacteroides overgrowth. Bacteroides is one of the most antibiotic resistant strain, and again, it needed over 1 year to normalize this. It was just 2 examples. We have many, many more because we pay a lot of attention on those intestinal issues in Lyme patients. So, at the end, the overall high expansion of undiagnosed Lyme disease cases worldwide might be linked to the screening choice focusing only on Borrelia burgdorferi and Sulato, and only rarely testing for Borrelia miyamotoi, while the later one seems to be much more prevalent. The further accumulation of the data might bring the answer to the question, are we searching for a wrong culprit? And searching for the actual bacterial presence using phage-based testing might pacify the debate and controversies on testing choices in late chronic stage patients. The overall high failure rate of therapies for vector-borne infections, especially those late patients, underscores the necessity to fully investigate different concurrent infections along with resulting gastrointestinal and immune dysregulation, and of course, to testing for different co-infections or opportunistic infections. I would like to thank you all for your patience and your interest, and also to express our gratitude towards the patients and veterinary doctors who send their ticks, practitioners who send us samples for testing, laboratory staff, Felix Charity, and University of Leicester. Thank you.